Hello, welcome to today's training, Strengthening HIV Prevention for Patients with Mental Health and Substance Use Disorder Needs. Today's training is designed to equip you with the essential knowledge and practical strategies for better serving individuals navigating both mental health concerns, substance use disorder, and risks associated with HIV. Understanding the intersection of these challenges is key to creating effective prevention and support frameworks within our healthcare systems. Throughout this session, we will explore the unique needs of this population by discussing the barriers they face and identify interventions that can improve overall well-being. Today's session is being facilitated by myself, Austin Puka, she, her pronouns. I'm a senior program manager with Corporation for Supportive Housing, and my colleague, who I will let introduce herself.
Hi, everyone. I'm Kristen Kalla, she, her pronouns. I'm based in Phoenix with the Southwest team at CSH. Just so everybody is aware, my background, I'm a public health medical anthropologist, and I've worked about 30 years in the HIV and AIDS sector. A lot of that has been working international for UN agencies, as well as the former USAID and, of course, the CDC. But I've also been a CEO running an FQHC here in Phoenix, which is an AIDS service organization, which integrated actually behavioral health, substance use disorder programs with our HIV prevention, care, and treatment. So happy to be here with all of you and looking forward to the discussions.
Thank you, Kristen. And that leads us right. Kristen was saying a little bit about what is CSH? What do we do, right? CSH is Corporation for Supportive Housing. And it's a touchstone. We're a national nonprofit that is aimed at bringing new innovative ideas and best practice strategies to our field, right? Our healthcare systems, our supportive housing partners, and all the partners in between that help us integrate and improve the care that we provide to the community. So here at CSH, we do training and technical assistance and education with communities. We do direct consulting and assistance. We're also a CFDI, right? So we do lending and help fund capital projects across the nation and support policy reform. Today's training is brought to you by the National Training and Technical Assistance Partner Program, right? So this free training is designed to support existing and potential health centers and lookalike programs, right? We're funded to provide training and technical assistance to health centers in a way that increases patient safety and improves health outcomes, right? We aim to really support health centers to effectively serve their communities, folks that are underserved in rural and urban populations. Right? And so our training often takes place in the forms of learning collaboratives. We design toolkits and infographics and newsletters and fact sheets. And you can find that information at the National Clearinghouse and at the different partner organizations listed on this site, on this page's websites. Thanks for being here. Right, so we're here for this training. Why does it matter, right? This training is really important, right? It provides healthcare professionals with the essential tools and strategies that are needed to really effectively integrate HIV prevention into the mental health care that our patients deserve, right? This training is aimed, right, to help health centers and providers both address mental health challenges and HIV risk simultaneously, right? And how it provides, the intention is to support providers to deliver more comprehensive and patient-focused care that aligns with the public health goals of your respective communities, right? Reducing poor health outcomes, right? We know that individuals with mental health challenges often face barriers, right, to consistent care. They can experience heightened risks to HIV. So this training will support, right, equipping all of us, right, all of the participants to better identify uh, those needs, right, and to address those health outcomes and ensure, right, increased access to those preventative interventions, right, such as pre-exposure, post-prophylaxis, right, PrEP, routine HIV testing, and connection to their substance use support and medication that may support. Right. And then we want to improve outcomes, right? If we can enhance our care integration, right, we can connect folks to the interventions that can improve their health outcomes, then we should see improved health outcomes, right? When we focus on practical and person-directed care strategies, right, we enable providers to foster strong patient engagement, help them reduce risk behaviors, right? We help folks create sustainable pathways to improving the outcomes for their at-risk communities. So the intersection, right? It's the intersection between mental health and HIV prevention. Mental health and HIV prevention, they're deeply connected, as mental health and substance use disorders can impact both HIV risk and health outcomes, right? So we see here, we think about mental health challenges and their connection to HIV vulnerability, right? Individuals with, they're living with mental health challenges, right? We mentioned that they can face barriers to the consistent care, right? And the ways that that increases vulnerability to HIV, right? Conditions such as depression, anxiety, and substance use disorder, right? That lead to risky behaviors. And we think about unprotected, right? Or sex without a barrier method, sharing injection drug equipment for folks that may be, right, inactive in their substance use disorder, right? And all of these behaviors heighten the risk of HIV transmission, right? And that when we think more deeply about the risk behaviors and what that connection to vulnerability, right? We know that mental health issues, right, how they're closely tied to those behaviors and how they raise risk, right? Inconsistent use of barrier methods, right? Our patients' access to education around injection drug practices, right? Needle sharing, right? Our ability to implement different approaches to cleaning supply equipment as we're working with folks through their substance use disorder, right? And those factors, right, they also disproportionately affect folks that are living with mental health illnesses, right? And they're not connected to care, right? And so knowing that those are what our participants, what our patients are facing, right, helps us to really see what that need for targeted interventions is, and that the impact of having, right, a continuum of care that is integrated across providers, right? So we know that any sort of challenge in a person's life, right, is going to disrupt their care, right? And so when we add additional barriers to the barriers of life, right, such as untreated, right, or maybe undiagnosed if folks are not yet integrated into behavioral health, mental health care, right, it disrupts that care continuum, right? It disrupts them coming to appointments with their providers. It disrupts getting viral labs to see how, right, our medication is working and how our viral loads are being maintained or suppressed, right? So when you think about issues like depression and anxiety and the ways that they reduce adherence to our antiretroviral therapy, right? That engagement in care, right? And that experience, right? That impact on that care continuum, they undermine the treatment outcomes that we're all seeking to support our patients with, right? So emphasizing right? This training will help to emphasize the importance of that integrated mental health care with right wraparound and person-focused HIV services. All right, and some statistics, right, to help us like really why are we here, right? So, right, the US HIV epidemic, right, is really significantly intersects with mental health, right? It underscores the importance of a comprehensive approach to care. We see that currently approximately 1.2 million folks in the United States are living with HIV. Yet only, right, an estimated 13% of these individuals are aware of their status, right? Uh, and that really highlights the need to expand testing and education efforts, right? Injection and drug use, right, is a major contributing factor that counts for roughly 10% of new HIV cases each year, right? And really, like nearly half of those, 10% new cases, right, of folks newly diagnosed, are also experiencing co-occurring mental health disorders, right? And that complicates treatment adherence even further, right? Uh, so we see this number here, right? 27%. That's sort of an alarming number, right? That 27% of individuals with HIV have an unmet mental health service need, right? And that critical gap in care is something, right? That's why we're all here in this session together, right? We recognize that it does need to be addressed, right? To really support improving both the physical health outcomes of our patients and the mental health outcomes of our patients, and like to sustain their relationships with us. Right? There's some more statistics here, right? And I failed to mention at the beginning of this presentation that this webinar is being recorded and these slides will be available, right? So you'll be able to access these sources and really dig into these numbers, right? But these are just more statistics, right? Um, of what the experience of folks living with HIV, diagnosed or undiagnosed, that are not connected. And that brings us into our core principles.
Great. Thanks so much, Austin. And just to remind everyone, there'll be an opportunity at the end of our training to answer any questions. We can also have discussion. And if you have anything you want to ask, please drop it in the chat. Austin will be sort of monitoring the chat function. So please go ahead and feel free to do so. So, okay, let's review the core principles in HIV prevention. We probably have a lot of people in the training that are already aware of this, but it's good for us to kind of go through these principles. And HIV prevention strategies are guided by these principles, and it's sort of common through most programs. One area is education and awareness. Spreading accurate and accessible information about HIV, including how it spreads and the way it can be prevented, is essential in any program. And we'll talk about the modalities in terms of how you're delivering that information a little bit later. But it's important that we are equipping communities with knowledge, and this helps to really address any stigma and encourage safer behaviors in the broader community and also with specific populations. Second core principle is condom use, and this is consistently and correctly using condoms, and that still remains one of the most effective ways to prevent sexual transmission of HIV. A third core principle is testing and early diagnosis. And that means that regular HIV testing is critical for early detection. Discovering HIV early allows individuals to begin treatment promptly and reduces the chances of transmitting the virus to others. And then finally, antiretroviral therapy, ART, and this is encouraging access to ART is really key, and getting people on treatment as early as possible. And this can suppress the virus, and improve overall health outcomes and lower the risk of transmitting HIV further. And then we have PrEP, which is pre-exposure prophylaxis, and we also have something called DPEP or PEP. And I'll talk a little bit about the differentiation between the two. But the pre-exposure prophylaxis, so PrEP, is a preventative option for people at high risk. Okay. And then PEP or DPEP offers a way to reduce risk of infection after possible exposure. So, PrEP involves the daily use of antiretroviral medications for individuals at high risk for HIV and to prevent infection before exposure. And this is commonly done with prescribing medications for PrEP, including drugs that are in combination form. And it works to block HIV from replicating in the body if exposure occurs. Okay, and this is a little bit different than PEP. PEP is intended as a one-time emergency intervention for individuals who may have been unexpectedly exposed to HIV. So this can happen through unprotected sex, needle sharing, or occupational exposure. It must start within 72 hours of exposure and is taken daily for 28 days. Okay. And so, what is DPEP? DPEP is a preventative strategy, and we often integrate this with HIV prevention, but it's a preventative strategy for any other sexually transmitted infections that are bacterial in nature. And this is designed for people who may be having regular high risk situations, inconsistent condom use, or just ongoing risks within sexual relationships. DPEP involves taking doxycycline based on specific exposure events, such as immediately before and after potential risk. Okay, so that's often integrated as part of the PEP strategy. And this is primarily for high risk populations, so gay, bisexual men, and other men who have sex with men, and often with transgender women. Okay, and then finally, community engagement. And this is about partnering with affected populations and ensuring the prevention strategies are effective in addressing their needs in various groups. And this can happen through various service providers, various communities that have people with lived experience. And it really just depends on your community and how you're delivering your services in terms of who and how you want to engage. So these are sort of the core principles. We'll move on to the next slide, Austin. Great. I already sort of went into, but this is just some greater detail about the preventive methods. And again, you'll have access to these slides and any links to resources on the slides. Okay, we can keep going. I also want to add a couple of other prevention methods that we often miss. And it's important for us to also remember mother to child prevention. It's important for us to consider preventing mother to child transmission, and it's a critical element in combating HIV. And this method involves providing antiretroviral therapy to HIV positive mothers during pregnancy, also during delivery, and also while they're breastfeeding. This intervention can significantly reduce the risk of transmission to the infant, and that's important. It's important to keep the viral load down also for the mother. And also early testing and timely medical interventions for infants is also equally important, especially those that are being born to HIV positive mothers. So that needs to be part of any key prevention methods that you introduce as part of your program strategy. Another area is male circumcision. And male circumcision is another proven preventative measure. We talk about this a lot in other countries, but also here in the U.S. And it is about 60% effective in reducing the risk of heterosexual HIV transmission. So it's another very important method to consider as part of your prevention strategies and part of the strategies in terms of having referral services under your program. I've already talked about education awareness and community engagement, so we'll just go on to the next slide. Okay, so let's review mental health interventions and how these relate to HIV prevention strategies. We know that mental health interventions are crucial. We heard Austin talk about some of the statistics and issues that we need to consider in terms of how these two areas relate to each other. Because addressing the psychological, social, and behavioral factors are often accompanying with HIV risk. And these interventions can help promote safer behaviors, reduce stigma, and improve treatment adherence among individuals living with HIV. And so, what does that mean in terms of thinking about the mental health or behavioral health strategies and how you integrate that as part of your HIV prevention, care, and treatment programs? One area is mental health and social interventions, and this focuses on addressing external and internal factors like stigma, mental health, substance use disorders, while fostering support within peer, romantic, and broader social relationships. So, just thinking about that from the social perspective and thinking about that programmatically in terms of how we're engaging individuals as well as couples, which I'll talk about in a moment. Individual level interventions, innovative tools in terms of engaging individual clients. That includes mobile and online technologies. And that can empower individuals with accessing information related to home testing, related to accessing services, related to providing various supports around treatment regimes. And this can really help individuals that are struggling with going in for services. And so you can really kind of reach out in a more mobile way, on an individual way, in terms of reaching out to them on a regular basis. And then we have something called dyadic level interventions. And this is where we work with couples and friendship pairing strategies. There's something called a trust model, and I'll talk about this in a moment, but this really works to enhance self-testing behaviors and adherence to ART, but done so within couples and pairings. The trust model focuses on building that trust and communication between partners and to enhance healthy related behaviors and outcomes. At its core, this model aims to foster mutual support, accountability, and shared responsibility, particularly in the context of HIV prevention and care. And by incorporating these elements, such as facilitating discussions, joint decision making, and collaborative goal setting, the trust model encourages couples or pairs to engage in self-testing for HIV, adherence as a couple to antiretroviral therapy, and maintaining open lines of communication about their health. This approach not only strengthens relationships, but also addresses barriers such as stigma or fear that may hinder individual health behaviors. And just there are sometimes limitations related to this model in terms of engaging with couples, but we've seen really great uptake in terms of health behaviors and antiretroviral drug therapies when you are engaging both friendship pairing and couples-based pairing. Okay. There's also organizational level interventions to consider, and that aims, and we'll talk a little bit about how to deliver these services and the different models around delivery. But this often means we co-locate clinical services or other HIV prevention care and support services to streamline access and reduce logistical barriers for populations through tailored service delivery models. So whether you're providing behavioral health or mental health services and want to integrate the HIV prevention care and support services or vice versa, right? So we'll talk a little bit about what those models look like in terms of operationalizing them. And then there's also something called multi-level interventions, and this is adopting a broader community-focused perspective to target structural, environmental, and economic determinants impacting HIV care. And so this is really about your partnership and stakeholder strategies in terms of what other organizations outside of your organization are you engaging with for the purposes of referral services, for the purposes of education and awareness raising, for the purposes of engaging people with lived experience and their families. So that's what we would consider as a multi-level intervention. So you would think about your own service delivery and then how you're reaching out to the community at large. Okay, so person-directed care is also really important for us to be mindful of, and this emphasizes tailoring healthcare services to meet the unique needs, preferences, and circumstances of each client. Um, a cis woman who is HIV positive will have different needs, obviously, than a gay man. And so we need to be mindful about how we're designing programs, and how we're designing materials and what the programs are offering to specific populations. But this approach is important in ensuring that we are transitioning individuals to what we call a status neutral. And so we'll talk about what that means, because oftentimes when you are delivering HIV prevention care and support services and they are designated as such, this can oftentimes also add to additional stigma, as opposed to integrating those services in a broader service delivery framework. So that's why we call it status neutral. So it doesn't matter what someone's HIV status is, that they are coming to holistic opportunities. We are dealing with a whole person, addressing client needs, not just regarding their HIV status, but also thinking about other services, which could range from medical, psychosocial, other support services. So it just sort of normalizes HIV prevention and care within a broader range of services. Okay. Um, so that's what we mean by status neutral. We'll see a couple of different models that incorporate this, and we'll have one case study that we'll also review with all of you, that shows you how they've been operating this type of model. Okay. Okay. I think before I wanted to see if I want to talk about anything else related to this. I think I actually I'll use this slide. It's okay, Austin. I do want to give some examples and go a little bit further around service delivery approaches and what that means when we talk about sort of neutral, status neutral. So this is how it would sort of operate. You would have a kind of welcoming environment, which would be part of a routine, inclusive intake of a client. Um, and again, as I mentioned, you would have a variety of services. In the organization I ran here in Phoenix, we even had naturopathic services. We had testing services for HIV, but also testing for other sexually transmitted infections. We had testing for TB, Hep C, and we had other types of services in this context here that were focused on LGBTQI plus health. Um, so again, we had breast screening treatment, and services. So it was really a broad, holistic range of services depending on the client's needs. Excuse me. So if a client was negative and decided to go through testing, and then we would offer a full range of prevention. It could be they wanted to talk to a counselor about their behaviors, or they wanted to engage in obtaining prescriptions for PrEP, which can often happen, to reduce any future risk of transmission. And then they would be referred off to other services. If a client would be positive, they would receive immediately linking to care. And this would be about initiating access to antiretroviral therapy, providing that case management support around them in terms of accessing other services that they may need. But really, the focus on this would be, and the goal is reaching viral suppression, so that ensuring undetectable HIV. Um, and so, we would have different referral sort of needs and cycles depending on the need of the client. Um, and then if you wanted to look, we have several places in Phoenix, which I haven't put in the case study, but there's an area called Spectrum Medical Care, which is here in Phoenix. If you want to look it up online, it's actually quite interesting. They practice specialized and personalized care, broad spectrum care in terms of medical care, but they have mobile testing after dark programs. So they go out onto the streets and provide mobile testing, and then link any client services from their testing operations that are mobile. It's also helpful in terms of rural settings as well. There's another health center called CAN, Community Health. And again, this is another kind of full service medical, psychosocial, and preventative care related to HIV, but also in a broader sense as well. And we also have something called Valleywise Community Health Center in Phoenix. And this is a comprehensive hub that specializes in HIV, but links very much to behavioral mental health, medical care, and dental care. Okay, so it just depends on how you want to organize your services. Um, so, in terms of person-directed care, I think I've gone through this. One thing that's important to note is however you structure your services, it's important that you have a comprehensive client needs assessment. And this means that you're conducting a thorough assessment to identify both the medical and non-medical needs, such as housing, legal aid, transportation, social support, when someone comes through your services. And there's lots of I think great tools around needs assessment. I think Austin's going to talk a little bit about just some examples, but we can also talk about that further. It's also important that you have someone supporting navigation and active referrals. So this can be a case manager, or you can have navigation services. And this ensures that you're seamlessly connecting your clients to services by providing active referrals and direct navigation support. And this ensures that you're reducing any gaps around care, which is really important, and that you're having follow up with clients. And then you need a kind of reassessment of your care plan with each of the clients to ensure regular follow ups and that you're evaluating those follow ups and addressing any evolving needs. We work a lot with the unhoused population, so you can imagine that their needs can be unique to, someone who is not unhoused. And so you can really assess any of the barriers and challenges the clients may be experiencing in maintaining their continuity and adaptability around their care plan. And so that's all part of a person-focused technique. And one thing, or two things I want to also mention here, which is really important to remember, is establishing trust with your client without judgment. And so building that rapport with your clients by using warm introductions, active listening, demonstrating genuine empathy. Everyone comes with their stories, comes with their traumas, comes with their lived experiences, and doing that in a way that's non-judgmental. And I think we probably have a lot of mental health experts in the room here, but I just wanted to stress that that's certainly important for fostering a safe and trusting environment. And then the other thing here is using conventional language, right? Sometimes those of us who are from these sectors tend to use very technical oriented language, but oftentimes clients just want us to make it clear and easy for them to understand, relatable, free of complex jargon. And that's certainly important, and code switch when necessary, depending on the population that you're serving. So I've already kind of mentioned a little bit about how we're going to integrate these strategies around providing mental health services and HIV prevention, but there are some specific models that we can consider. One is a collaborative care model, one is strategies for care integration as part of your existing model. We'll talk a little bit about some assessment and screening tools, which I mentioned earlier. Those personalized prevention plans, which I also reference, and kind of what goes in those. And what does it mean to have community partnerships and outreach? Okay, so let's just kind of go further. So, collaborative care models. We have a couple. One is a primary care mental health integration model. And this combines medical and mental health services within a single setting. And it provides patient focused, coordinated care within that single setting. This model enhances collaboration between providers and aligning treatment plans to address both physical and behavioral health needs. It prioritizes a holistic approach within this model and aims to provide overall quality of life for individuals with streamlining care delivery. So, you would be integrating your HIV prevention care and support through the model that already exists in terms of this integrated mental health service delivery model. Something else to consider is settings around integration. What does that mean in terms of your structures and systems? Um, and we have to think about this depending on the context. We can have primary care clinics, hospitals, community health centers, even mobile medical units. We have quite a few of those here in the Arizona area, but and I'm sure you do as well in different areas where you also have rural populations. Um, and so to think about how are you going to integrate your HIV prevention care and support through any existing models and how they are structured. Okay. And what are the points of integration? And so those are all things to think about structurally. And one good resource for this, which probably in the room everyone's aware of, are the SAMHSA framework, and this kind of goes through the degree of integration in terms of your services that you're providing around behavioral and mental health, and identifying that sort of continuum from minimal collaboration to full integration. And so this is a really good framework to use when you're thinking about redesigning your programs or strengthening your programs. So we'll kind of go through some of those categories now. Okay, so this is part of the SAMHSA framework. I really encourage you to download, take a look at this if you're thinking about redesigning some of your services or strengthening. Um, so these are the different categories. You have coordinated categories. So, what does it mean to coordinate? And that's kind of a minimal collaboration. And this is when providers operate in separate buildings, communicate infrequently. I think we've all often experienced this sometimes when we're providing services. There's little to no system integration, and services are delivered independently. So really, it's up to the client or patient to go and figure it out. And they may find that experience very fragmented in terms of their care, which also has risks for them in terms of, especially those who are living with HIV, in terms of ensuring, their care and treatment plans that they're adhering to them and have the necessary support. Level two is a kind of basic collaboration at a distance, and that's when providers communicate periodically, but they still are located in separate facilities. And although there's some exchange of information, care delivery remains a bit siloed, and collaboration is limited to occasional updates. So then we're going to co-locating category. And so we're getting a bit better here. Level three is sort of basic collaboration on site, and providers are sharing the same physical location but maintain distant systems and workflows. So those are not integrated structurally across the organizations. And while there's proximity, that helps with improved communication. I've operated under this model. So it does help. And a lot of that is about building rapport across staff, oftentimes, excuse me, across the organizations. It's still your care integration is a bit limited. Okay. And level four is getting a bit closer, where you have a partial integrated system. Excuse me for a moment. Where providers are working on site with more increased communication and share some processes and systems. So this can sometimes happen when you have relationships and memorandum of understanding with another type of provider who is coming on site to your organization and integrating through your systems and providing technical expertise because you are contracting out that expertise, okay, and some level of support. So this kind of is marking, sometimes when we're thinking about integration, this can kind of be a good step for building in integration where you are contracting out certain services and having them being delivered on site through your organization. Now, when we're going to more integrated categories, I, yeah, um, more integrated categories are sort of level five and level six. And actually, I think it's a slide forward, Austin, or backward. No, it's backward. Sorry. Yep, I'm still there. Level five, this is where we're getting into some really strong integration. And this is close collaboration approaching an integrated system. Providers are operating in a seamless manner, functioning as a cohesive team across different services. patients begin to experience care that is more holistic and unified, closely aligned to the processes that are usually enhanced through coordinated service delivery. And full collaboration represents the highest level of integration, okay? And that's when patients are receiving complete one system care and support. It's cohesive. Your systems and processes are interacting with each other. And so any monitoring in terms of care plans are all integrated in one system. Okay, thanks, Austin. We can go forward. So it's just this is just about how sometimes as part of thinking of care integration, it is about we'll have experts both on the mental and behavioral health side, substance use disorder side, HIV prevention care and support side. It is about getting everyone in the room. And I know when I've had to structure services that way, it's really important to have everyone be part of reviewing your systems and service delivery. It's important to have them be part of the designing, part of the evaluation, and part of case management in terms of consulting on cases. Because if you're only engaging one level of service, you're going to miss out issues on other services, right? And so it is important that you're having regular consultations with the full team across all services. And this is really about interdisciplinary teamwork. And I think the health sector can do that quite well, especially if you have a public health model around your service delivery. But I do think sometimes we can get siloed. So it is about thinking about how you're enhancing communication and coordination across the disciplines, because at the focus, it's really about putting the patient care in a holistic way at the center of your services. Okay. All right, we can go on. Just some strategies to consider here, additional strategies as part of integration. Um, one key strategy is involving embedding a behavioral health nurse as a care manager as part of integrated services. And then you can have a consulting psychiatrist within clinic operations. This is how I structured the program here in Phoenix. It was more focused on HIV prevention care and support delivery, but I contracted out to other entities to have behavioral health nurse care managers and a psychiatrist that came twice a week and reviewed care plans, wrote scripts, and that was just really helpful. It was also helpful in terms of the budget, the operating budget. At the time, we couldn't afford having a full-time psychiatrist and full-time physician on staff. But this also ensures that you're having some specialized expertise, right, in conducting mental health assessments integrated as part of your HIV prevention care and support work, and that you're having multidisciplinary case reviews, I think is really important. This speaks again to that kind of integration across sectors. And you can have HIV physicians that are also on contract coming in, not full time, but those multidisciplinary case reviews would include the HIV physician, the behavioral health nurse, care manager, and any consulting psychiatrist. So they would be part of reviewing care plans. Oftentimes, the case manager as well, or any navigator, can also be part of reviewing case reviews just to ensure that we're having progression with patient outcomes. The other thing to consider is population registry and tracking. What does that mean? Oftentimes, they can be separate and different for mental and behavioral health versus on the health side of things in terms of HIV care and support. So, developing and maintaining a structured patient registry is crucial, that is integrated as much as possible. And it's helpful because otherwise you won't have patients kind of fall through the cracks in terms of some aspects of their care plan. And what does that mean in terms of electronic health records? I'm sure there could be a whole session on this, but that can sometimes be challenging. And then, of course, if you're looking at billing, which we're not talking about in this training, but but obviously that's all sort of related structurally and systemically in terms of medical health records, billing, and so on. So just thinking about this in terms of your systems and processes internally if you're looking at integration. Okay. One thing that's also important is the pharmacologic management for certain disorders like opioid use disorder and depression, and how you're integrating that level of support. And what does that mean in terms of clinical support? Is there some level of flexibility for providing services to walk-ins to your facility? What does it mean to provide immediate care? What does that mean? Not just connecting that to your HIV prevention care and support services, but, oftentimes you'll have people just coming in off the street looking for that type of robust, immediate care. So again, thinking about how you'll be delivering those services if you incorporate substance use disorder services as well. You'll obviously be having to think about the clinical support needs and pharmacological support needs as part of that service. And then finally, measurement-based adjustments. Just continuously monitoring and assessing a patient's progress is really fundamental to care integration. I think many of you will know about the PHQ-9 scores, which is that kind of 9-question screening tool used to assess the severity of depression, for example. And this can also be integrated as part of your HIV care. But it helps to evaluate symptoms and any improvements around depression. So again, thinking about the kinds of assessments you're using as part of your case reviews and support to clients will be important. And you know, structured kind of adherence and metrics with medication for opioid use disorder will also certainly be part of a care plan for those who are experiencing substance use disorders as well. Okay. And then finally, all of this, again, if you're going to be focusing this from the perspective of HIV prevention, care and support, we have something called personalized HIV prevention plans. And again, each sector will have their own plans, behavioral, mental health, you have your plans as well. But I'm just going to tell you from this perspective, we just want to ensure they're person-directed approaches, so tailored to specific population needs, which I mentioned earlier, considering factors such as mental health, lifestyle, so questions about their lifestyle, and personal preferences are considered as part of the HIV prevention plan. And it's ensuring that it's really reflective of the client's needs, as well as their need any needs in terms of, especially if they're living with HIV, in terms of ensuring needs around their care. But also looking at reducing further risk and personalizing those plans to minimize any additional exposures to HIV is something to consider with the individual. And this is often managed by the case manager or navigator in terms of helping to develop these plans. And finally, ensuring any adherence to prevention methods, whether that's PrEP or antiretroviral drugs or PEP and so on. And this is really important where you have the linkages to the other services, clinical services as well, in terms of the pharmacopoeia. So, okay, I don't think I have anything further on HIV prevention. I think I'm handing over to you next, Austin.
You are. Thank you, Kristen. All right. And we're getting towards the time when we will do some case studies and we will turn the session recording off and have some dialogue together. So thanks for those that are here. Right. So Kristen, right, in talking about HIV care, how do we integrate services, spoke a lot about assessment and screening and the importance of it and how we use it, right? And so like recognizing like screening and assessment, they're two different processes, right? So screening, right, is that process for identifying that there's just even a presence of a particular problem, right? It's kind of how I look at like progressive engagement, just really how do you build rapport and trust, right? assessment, right? That's that process for defining the nature of the problem, right? And that's where you start to develop specific, like targeted interventions, right? Which Kristen was just speaking about, right? And so in some of those examples that we received, right, for what screening and assessment can be used for. In the previous slide, we were just talking about that personalized HIV prevention plan, right? And right, how do you develop a plan that leads to improved health outcomes independent of knowing what are all like the problems that may exist so that you can be thinking of person-directed solutions. And so some guidelines and best practices for screening assessments, how we develop them, how we use them, right, is to really right, embody that understanding of treatment as prevention, right? When we enhance treatment, right, and that enhances someone's outcomes, their adherence, reduces risk of transmission, right, increases that undetectable and that reinforces our overall public health message and how we support folks living with HIV, improve their health outcomes, and reduce the risk of other effects. When we talk about that non-judgmental care, right, patient-focused approaches, right, this is how we engage with our patients and the training that our staff and that continuum of care that is supporting our patients. And I see a lot of them in the room, right? We have range from directors, we have community health workers that are so important in integrating services, case managers, medical case managers, right? And so how do we like support those teams and provide them tools and interventions that allow and facilitate that non-judgmental care, right? And that takes us right into right, staff trainings. How do we help our primary care providers really see the value of the screening and assessments, right? Like reevaluate those screening and assessments because of their value, right? To ensure that they are meeting the needs of the community, the public health needs, and supporting some of those really important strategies and approaches that Kristen spoke about, right? Around really being able to direct referrals appropriately and being able to reduce stigma and effectively integrate. So supporting your whole team to really evaluate what are the tools that we're using. Are they effectively serving people? Do they capture all the right information, right? If not, what is it missing, right? And how we do that in coordination and collaboration with the different stakeholders, right? Partners, that includes our patients, right? So how we kind of move from thinking about it functionally, but doing, right? There's that preparation phase, really thinking, what is the purpose of our tool? What is it used for? Are there barriers to utilizing our tool, to it being effective, to people accessing the tool, right? Are there strengths of the tools that we have that we want to highlight? And if we are working to coordinate, right, co-locate, collaborate, can we use the strengths that we see in a particular assessment or screening tool to help improve another, right? And then really in that preparation, all the preparation and all of the research can only be well-intentioned if we don't have a mechanism for then determining an approval when we want to make an improvement or a change, right? You identify, right? You kind of do your own internal gaps analysis, see, right, that preparation, then you start to identify what's the tool that you are going to use, right? And Kristen gave us examples of some models and programs that utilize them, right? But we want to be focused on how we reduce burden, not just on our patients, right, and their access and seeking their care, but on our field, our people, right, our staff, our teams. So where are we selecting something and bearing in mind that it's timely and it's effective, right? As integrated as our services can be, there probably still never be enough of us. So how are we reducing staff burden as well as patient, right? That importance, what Kristen was speaking about it on the last side of the importance of health literacy, right? folks' ability to understand the information being presented to them in a way that lets them make informed decisions about their care and their involvement in their care, right? And we want to make sure that we're selecting tools with not just involvement of our decision makers and our persons that are going to determine that approval, but our staff, right? Kristen spoke about those collaborative teams coming together to develop those plans. And it's not just the practitioners that are prescribing, it's not just our mental health professionals, it is our case managers, right? The folks that are doing that work to support a patient in the goals that they identify that directly relate to the needs we're seeing in their assessments, right? And how, right? Yes, this training is not about documentation and billing. If you want to talk about it, pop your email. We can tell you about other trainings that are to focus on that, right? But we know at the end of the day, we all need to document. If we didn't document it, it didn't happen, and we need to be able to bill it. So when we're thinking about preparation, when we are preparing, when we're identifying solutions and improvements we want to make, and we're selecting tools, we want to be making sure that there are things that we can effectively deploy with our, requirements, right? And once you get all that figured out, anything's only effective as someone's ability to use it. And so we think about staff training and education, right? You don't want to, when we think about timely and effective, you don't want to select a tool or update a screening or assessment just for the purpose of to do it, right? So you got to really identify that there's a need for it. That's how you get buy-in and staff that participate in the education and utilize that tool. All right, you want to define expectations. Right? In the previous slide, your screening and assessment tools, that's not the solution that brings the folks to their improved outcomes, right? So we want to be able to define expectations, not just with staff, right? That helps reduce their burnout, right? To recognize what is this tool designed to do, and then what's the work that the tool motivates, facilitates to get us to that ultimate desired outcome and expectation of improved health outcomes. And when we define expectations with our staff, it allows them to be able to define expectations with our patients, right? Right. And so we do that. We develop manuals, resources, right, that are accessible, that highlight the importance of literacy. They have to be usable by folks, right? And we have a mechanism and a commitment to evaluating the effectiveness of the changes that we recommend, right? And that leads us to continuous quality improvement. It's part of why we're here, right? So we don't make change for change's sake, and we don't just collect data for data's sake. We want to use that information. We want to analyze what we're learning from it, right? To Kristen's point earlier, how are we tracking the treatment referrals that we're making? How are we tracking when we can't make a referral so that we know that might be someone we want to engage and make a connection or partnership with, right? How are we taking the data and looking at the outcomes of our patients and using those outcomes to go back, right? It's the cycle of continuous quality improvement and make additional changes, right? And to be continuously analyzing the fidelity of a tool that we select. If we identified a problem and assessed a need, we want to be looking, right, reassessing, is the tool still meeting the fidelity of that need that we assessed and what we believed and the expectations we set that this changes we're going to support. All right. And in all of that exploration and right, what are our tools support? What don't they support? How do we want to improve something? That's where we highlight gaps, and that gives an opportunity for right, partnerships and outreach, right? And Kristen spoke about those partnership types, right? The levels of them, right? From we have our, let's see, I was taking notes too because we all, right? We have coordinated, right? That minimal and basic coordination, right? We probably know about each other, right? We're just sending those referrals and they happen, right? And we move to that co-located, right? That's that basic and close, right? People are in the same building, but what does that partnership really look like? How is it integrated, right? And that gets us to that full integration, that close and full, right? We move on that spectrum. So how do we do that? What are some like best approaches to keep in mind as you are moving from assessment to that gap in establishing partnerships, right? So once you define the gap, like we spoke about in the previous slide, then you bring the folks, right? You think collaboratively, where is this gap and who does this in our community, right? And you need to establish some sort of shared goals, right? If we're using all different assessments, where might our metrics and what we're trying to capture align up? Where do we share, right? In our HIV care goals with our patients, right? We have a goal of improving their outcomes, that undetectable, untransmittable. What are our mental health, our substance use providers' care goals for folks? They probably really align, right? Improving outcomes, retention in their care, participation in their care, right? And when you realize what those goals are, then how do you assess our capacity and the resources to meet those goals or to, right, to work together to try to meet them? When we think about capacity and resource, right, that is the time, right, the capital resource, but also the folks within our organizations are the resource that moves the changes that we seek to implement, right? And how do you build trust and generate buy-in, right? Kristen spoke about that trust model, right? And how it supports right, providers, and it helps them to teach patients on how they build trust with each other, right? And improve that communication. How do you do that within the partnerships that we create, right? When we know that we have a shared goal, right, how do we use that to build that rapport? And once you've like identified that model, right, then how do we develop a partnership and a structure plan that, right, timely and effective, and it is not burdensome on the system, the patient or the provider, but really does hold everyone, right, accountable and responsible to that, their shared commitment, right? And how do we put in mechanisms for that continuous quality improvement, right, implementing, testing, evaluating, coming back in that partnership and trusting framework that we've built to say how we want to adjust, re-implement, right, and use the data to help us scale and sustain our improvements. And there's a source here, and you get these slides that can like dives into these like best practice approaches and these types and how to really make that strategic approach within your organization. All right. We're getting towards the end, and we're going to chit chat together, right? Talk about some case studies, and we intentionally are in a Zoom meeting space rather than in a webinar, so that folks can participate as they feel comfortable to. Right. So we're going to talk about some like a successful integration of a health model and programs, and kind of highlight some of those practical examples from real world settings, right? You come to these webinars, that's great. How do you then take this and deploy it, right? And when we look at it, right, that helps us to identify what are some like actual replicable solutions that we see in these real world examples that, right, some kind of short-term goals, we can do that right away, and some things that we can really think about and develop an approach around. All right, so we're gonna have video time, and then we'll pull this down and have a chit chat, and I'm gonna have to launch an evaluation. So if you stay through that, I greatly appreciate it, right? So this example is in Chattanooga, Tennessee, right? It's a HRSA Ryan White HIV/AIDS program example that integrates mental health, right, with their HIV/AIDS care. And Chattanooga does some pretty awesome integration across a lot of the services in that community, right? This particular approach is, right, the clinic is integrating, right, their mental health services into the HIV treatment settings, right? And we think about, in the earlier slides, we talk about that connection for with anxiety, depression, and its impacts to adherence medication, right? And so what this approach does is kind of elevate those best practices, right? So that we can identify the unmet mental health need, right? And provide a solution and approach, right? It supports folks to make right, that gap of integration and that stigma reducing so that folks can engage in screenings to identify what their care is. So, right, you have folks that are implementing right, working with folks person directed to go through their social history, right, which can be a sensitive a topic to go through with someone, but that is how we get connected to the person focused care, right? And it really leverages the Brian White program and those resources to provide that holistic wraparound care, right? So when we think about overall service integration, not only are we increasing outcomes, but we are maximizing the resources within our community and maximizing our own organization's resources and helping us to maximize our partners. So we're going to spend a little time to look at this program, and then we will chat about it.
Chattanooga Cares was established in 1986, and we received our nonprofit status in 1988, so we've been around in the community for over 30 years. We are kind of the lead HIV organization in the area, so without Chattanooga Cares, a lot of the services that our patients receive would just not be here.
Without the support of the Ryan White program, our services here would basically look non-existent. Ryan White is really the cornerstone of all of the services that we're able to provide to our clients.
There's lots of clinics that will kind of satisfy the medical aspect of our clients' needs, but because we have kind of a wider scope of what we can do for a client, we can also meet their emotional needs with my services as well as client services.
When I first got here, I used to use a substance abuse program. I used a mental health program. And plus I used to get housing through Chattanooga Cares.
We, focus on the primary HIV care, but we also take into effect their behavioral health needs. So we do a depression screening at every visit. We go over social history, look at any drug and substance abuse that they may be struggling with.
We integrate mental health services into the treatment of HIV because it happens all the time. I know it's a big comorbidity with people with HIV, have substance abuse issues or mood disorders on top of that, as those two also have comorbidities. So without the mental health component, I don't think we'd be as effective as far as adherence for HIV medications or engagement in other services and general well-being.
It's very important for us to help our clients with not only HIV care, but also the behavioral health care, because integrating both of those can help our clients have a healthier life.
There's a higher incidence of behavioral health issues with people who are HIV positive, and that could be just because of their demographics or the struggles that they have to deal with as a community, or just the anxiety that they have with their diagnosis. And so I think without that component, there'd be a lot more issues when it comes to medical adherence, individuals taking their medication, and also just from a social service aspect of living a full and complete life.
The impacts we've seen here at Chattanooga Cares with behavioral, medical, and HIV care has been more engagement in care, more retention. Our viral load suppression rate is 89.5%, which has gone up significantly in the last couple of years. And our retention rate has also increased to 73% over the last couple of years.
Chattanooga Cares is all kinds of neat. They show their love, and when we come in, doctor's appointments, most I like is because they love us. They love all the clients.
To see their smiles when they receive services from our market, let alone housing. Just the fact that they can just call back, and I hear sometimes them say, I'm really happy about what I received, and you don't know the difference that you made. The fact that I can make an impact on people is the best part.
If we did not have the support of Ryan White, we would not have much in means of behavioral health. It really helps us as a last resort to assist with housing, with food, counseling, medical case management, and accessing their medications. No patient goes without getting care.
Right. Going to stop the recording now, and Kristen's pop back on is going to help facilitate some discussion about this example. And I encourage y'all to come off mute and share some discussion as well.
Hi again, everybody. So that's a really good, the Chattanooga Cares. Are we on?